Good morning, Steve Stites, Chief Medical Officer at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. Delighted to be back with you this morning, of course. Joined on the right by Doc Hawk, always a delight. How are you, man? Good. And we have three outstanding people representing respiratory therapy because it is National Respiratory Therapy Week. So Tisha Bromstead, if you're listening, thank you for all the great work you do with our patients. We're going to come back to that story more in just a moment. Hawk, how are the numbers?
Yeah, not good.
Yeah,
not good.
It's not good around the whole area.
Not good yesterday with our CMO call, just like you said. Not good today here at the health system. 36 active patients in, with 14 of those in the ICU and 8 of those on the vent. Ouch. Unfortunately, we still have 41 now who are in that recovery period, in that recovery phase, so not acute infection. So that's over
77 right
beds.
There. That's a lot of patients and a lot of beds, and that's getting to be a rising concern. The number of beds that are being taken and the number of beds available.
And Hayes has, just to let you know, 16 active, but 4 recovery, so 20 total. And I think they had 17 yesterday, so their numbers are up a little bit as well.
And they run out 88 beds or something like that. I mean, that's still 100 beds. That's a big number for their beds right now. Jill, let's start with our media questions. Let's see what we have out there this morning.
Do we have any on the line? All right, Katie with the Kansas City Star wants to know. The Metro saw the highest weekly number of COVID-19 deaths at 81. What is driving this? What do you expect to happen in the coming weeks in terms of the death rate, and how can we slow it?
You know, Katie, hope you're listening. That's a great question, and we're concerned. Right? We're concerned. You know, across the country, the COVID numbers are up 30 to 40% on the rolling 2-week average. So think about that. That's over a 2-week period compared to the prior 2 weeks. It's up 30 to 40%, and that trend's been going on for the last several weeks, in the last month or so. So we need to be worried that with schools reopening, people trying to gather more, a lot of COVID weariness, and people just saying the heck with the mask. The outcome of that is we're seeing more disease. We're seeing it more in younger people, and so that's helped prevent some of the hospitalizations and some of the deaths. But those numbers are starting to rise because it's again back in nursing homes, and again it's starting in schools, or starting in large gatherings of younger people who then bring it to an older population, and then what happens is people get sick and they come in the hospital and we see more death. I think we're nervous. We're nervous about our capacity. We're nervous about the capacity in the city. We're not able to accept as many transfers as we normally do, and that's true across our region. So I think there's cause for concern. And we're not alarmists on here. We're not flapjackers, and we're not going to flap our arms and jack with the truth. We're going to tell you it as it is. And the good news is there is a way to solve this. We know what to do. We've bent the curve before. We've bent it back in March and April. We've bent it in the middle of the summer. We can bend it again. But it's the rules of infection control that bend it. And those rules are known to you, right? You know the right choices. And the choices are shelter at home. Remember, we say a lot on this program, there's no place like home. That's really the answer. Wear a mask. Don't go out into large gatherings. And even though it is so tempting to think, oh, I'm trying not to get outside of my bubble, you got to really do it. And if you don't do it, there's a lot of COVID out there right now, and it will spread. And as it spreads, people get sick. And as people get sick, some people get sicker. And the ones who get sick are coming to the hospital. And some of those people get really sick and end up on the ICU, 8 on a vent. That's a high number for us. And then some of those people die. And that's what we're battling. We're battling the overall rise of COVID-19 caused by SARS-CoV-2 in the community, because people aren't being as careful as we were, and we've started to try to open things up, and we're seeing the repercussions from that. It's very simple, right? That it's the rules of infection control. They travel with you wherever you go, and even if you have the worst case of COVID weariness syndrome, the worst case possible, it doesn't change the rules. The rules are still the rules. And so, when you don't follow those rules, or you put our children, or our young people, or our families in harm's way, harm's going to find you. Because that's what SARS-CoV-2, it finds you. Remember, we said it before. SARS-CoV-2, it doesn't care if you have cows. Doesn't care if your kids want to be back in school. It doesn't discriminate. It doesn't care if you're a blue state or a red state. It doesn't care. You care. The only ones who could change this are you.
Yeah, I think it's just a pure numbers game, simple numbers. If we say 5% of people who are ill with COVID-19 go to critical illness, if you have 100 people that are infected, that's only 5 people. But if you have 1,000 people, that's 50 people. We know that the disease is out there, and it's just not just because we're testing. We could test or not test, but those people are still going to come to the hospital. That's not the point of this. And we have colleagues here at the health system now, just a couple in the last few days, who have no other known exposures. They've been very good throughout this. They aren't going out meeting in large gatherings. They have COVID now, so it is unfortunately out there in the community, and there could be, there's certainly, we know that up to 40% of people could be asymptomatic or certainly spreading it while they're pre-symptomatic.
Did you have another question, Joe?
We do. Cody with Channel 9 News wants to know, I'm wondering your take on the new CDC definition of close contact, showing potential exposure to infection is cumulative. What does this mean going into Halloween weekend?
Yeah, we talked a little bit about that last week, Hawkeye, and unfortunately their cumulative didn't really, cumulative over what period of time?
4 hours.
So let's talk a little bit about that.
Yeah, I think it maybe helps define it a little bit more, but I think the biggest thing to understand is the concepts, and we've been trying to push the broad concepts. That change was brought about by a MMWR report, a CDC publication report that showed that there was a prison guard who had several small interactions with inmates that totaled over 15 minutes, and so they went to make that definition. I don't think that changes anything other than continue to just understand the concept, really. You could walk through a large breath cloud of somebody who has it and get it. We know it probably takes a very small amount of virus to cause actual infection. So the more that you are with somebody in close spaces, the more risk you're going to have for getting the disease.
And we know that masking makes all the difference.
Yeah.
And we know that because here in the hospital, we're not seeing transmission in the units where there's COVID. And so if there's no transmission from patients to staff because the patient's wearing a mask and we're wearing masks and we're wearing goggles and we're taking all the right precautions, then there's something about masks that work. And that's what we have to remember. Masks work. You do have to wear it, though. It doesn't work so well if you got a chin mask or if your nose is exposed, it's on top of your head or it's not on your face. Then masks don't work very well, but masks properly worn. And we're going to hear this story in just a minute from respiratory therapy. Masks properly worn really do work. Is there another question?
Well, and a follow-up to that is with that cloud, is it more important to cover your third mucous membrane?
Oh,
that
we've
you
been
guys
saying
talked
from the
about.
beginning. It's always important.
Yeah.
Okay, where is it? I got him. To cover our third mucous membrane. And we carry them with us because whenever we're up around the floors, look at us. And I bet our respiratory therapists are going to do the same thing. And you know what? It does work. And of course, Dana, you and I look really good like that.
I know. I still can't go to the bar like this, so I would avoid that large gathering.
You could attract a lot of attention.
But I think we should still avoid those large gatherings.
I'm with you about that. I think you just need cooler goggles if you're going to go to the bar.
Yeah, maybe.
Okay, I've got some cool ones at home.
Yeah.
I can't wear them over my glasses.
Okay.
One more question from media. What to expect in terms of the vaccine? How long before we socialize and we can be safe? Are we talking months? Are we talking years after one is approved? And they go on to do math about how big the world is, how big the U.S. is.
Yeah, that's a great question. So, the answer is we don't really know, right? We don't really know. But here's what I would say. With masks on, just remember that life is already better because you can go out and do stuff. You can go to the grocery store, you can visit, you can go sit outside around a fire pit, and you can do all sorts of stuff. So it's not a zero-sum game, meaning you don't get to do anything. That isn't true. You get to do some things, it's just not normal. So then you ask a second question. How much can we do with a vaccination? Well, the problem is we don't know how well vaccines work yet to answer that question. That's going to be the critical one. The drumbeat, the very soft drumbeat that we're hearing, is that the preliminary data on vaccines look pretty good. which is something we're going to hope for. So let's work with that for just a moment. Let's assume that as we vaccinate the most vulnerable populations, and we vaccinate frontline workers, and we first responders and healthcare workers, we've already just taken care of a significant part of our problem, because by doing that, we actually create more capacity in hospitals because people are more protected, and we start to take care of the people who are most vulnerable for death around this. So that already begins to ease the burden a little bit. Is it going to be suddenly 2019 or 2018? Yeah, probably not. How far are we away from 2019 and 2018? Yeah, I'm going to say it's a year. Mm-hmm. But that doesn't mean we're not going to make incremental changes to that. It's not going to be an on or off switch. It's going to be incremental, and life will get better incrementally. Mm-hmm. The second thing I would say is that monoclonal antibody therapy, let's cross our fingers. Because if what we're hearing, that it's not hard to tell who got the drug and who got the placebo, well, that could be a game changer. That could be a real game changer. But even so, it will be an incremental change that will help improve our lives as we slowly head back toward normal. And I think we're going to get there. I just think it's going to take time. I don't know how much time until we see the actual results of those trials, Hawk.
Yeah, I agree. And I can't remember if it was Dr. Fauci who said it or a podcast or another article I read. I think there are gradations, and I think, it's not going to be on or off. But I think a lot of people, until we fully know the impact of the vaccines, but also there should be new therapeutics out. Hopefully there'll be oral medicines to take once you get diagnosed to help decrease your risk of severe infection. But I think a lot of people were talking, maybe Q4 of 2021 or Q1 of 2022. So just as you said, it may be a year away to getting back to more normal, but it's not going to be on or off. I mean, there will be a continued increase in normalcy from here on out for sure.
Yeah, I think we're going to get there, and I think that's where hope lives. Hope lives in science. A lot of people want to tell us that, science is... No. Hope lives in science. Think about science. Think what it's done for cancer. Mm-hmm. When I started in medicine, breast cancer was a deadly disease, right? And it's still a deadly disease. But, oh my gosh, people live so much longer than they ever did before. Lymphoma, non-Hodgkin's and Hodgkin's lymphoma. It's not 100%. But it is so much better. Lung cancer, so much better. So cystic fibrosis disease I treat has been revolutionized in the last year. And that was for the longest time hope. But hope is led by the science. And this science will get us there. And what we have to do is keep everybody and keep ourselves safe and keep our friends and our families safe, our loved ones safe, because science will help us get there. You have to have some faith in something. And, for me, I have faith in God, and I have faith in what we do every day here at the University of Kansas Health System and the University of Kansas Medical Center. We're trying to take care of folks, and we're trying to find new answers to do a better job of taking care of you with research. And I think that's where the science and the hope, that's where the two intersect. And I think that's what's going to get us out of this.
We do have one clarifying question to a statement that they think they heard you say.
Please.
And they want you to reconcile.
Okay.
We're doing everything right on the floors and it's not spreading, but we have staff that are getting sick.
But we believe the staff and the ones who are getting sick, they're getting sick outside of KU. Yeah. And we've traced that, and we're going to get to that story in just a moment because we're going to talk directly about respiratory therapy, and they're going to tell us that.
Yeah, and the people that I'm talking about aren't seeing patients on the floor. So
yeah.
All right, we are done with the media questions.
Those are big, hard questions.
Have
Great
a lot
questions.
of good ones coming up.
All right, well, we're joined here by Kyle Fitzgerald, who's the Assistant Director of Respiratory Therapy. He's sitting to my left. In Studio B, I'm not going to say this right. Kyle, how do I say his name right?
Belette.
Belette Ficru. How's that?
Yes.
I've seen Belette on the floors for years here as a respiratory therapist,
Absolutely.
but I don't know that I could say your name correctly then or now, and that is my apology. Belette is a respiratory therapy team leader. And also joining us virtually is Rick Coldry. I can say that name because he's kind of dorky. He's a PharmD and the Vice President of Pharmacy and Health Professions. So Kyle, How are things going for respiratory therapy? It is National Respiratory Therapy Week, and that's something for all of us to celebrate, especially those of us who are lung doctors who work all the time with these outstanding respiratory therapists, and I know belief from that. So talk to us a little bit, Kyle, about what's going on the floors, how's the equipment, how's your team, and have you had any COVID patients in your team?
We've had a few, yeah. I think as you guys have talked about. Yeah, it's been a tough year for everyone, I think, but everyone, especially in our department, has done a really great job and has gone like above and beyond, just making sure we're doing the best we can for all of our patients. And it's culminated with this week, as you mentioned, it's Respiratory Care Week, and we're definitely feeling the love and support from the community and from the hospital and everyone here to keep going at it and keep doing what we can to help everyone out in the community.
So you've had to cross-train a lot of people within respiratory therapy. Talk to us a little bit about what do you mean by cross-training? Because when I think of cross-training is how I exercise. But I don't think that's what you're talking about.
No, a little different. Yeah, a little different. You know, early on, we decided to cross-train a bunch of staff because, you know, we wanted to make sure we had the appropriate amount of staff to take care of whatever, you know, patient demand presented itself.
Yeah.
You know, we didn't know much in the beginning. We did know that RT would be a big role in the pandemic. Mm-hmm. And, you know, assessing different situations throughout the country, we knew that we may need to, you know, use some unique staffing strategies to meet the patient demand. And, you know, we really appreciate everyone who was willing to cross-train and help out during this unprecedented time.
Yeah, that's a big deal because we were worried we're going to run out of staff, and we had everybody trying to learn how to use anesthesia equipment for ventilators and stuff like that. And even as our numbers rise, I don't think we're going to hit that. Cross my fingers about it, but I don't think we're going to hit that. But, man, we were ready if that came to us, if we looked like New York, if we looked like Italy.
Absolutely. We definitely felt like we were ready.
Yeah, that's good. So Balit, tell us a little bit, how are the staff holding up that you're working with here in the pandemic?
I just want to say thank you to the people working in our department and happy Respiratory Therapy Week. My staff are doing their best, you know, to cope with the pandemic and go ahead and taking care of patients and taking care of their life and their family. And then I talked to several other RTs in our department that they are doing their best, you know, to go forward and, you know, to take care of this pandemic, you know, like taking care of their health and their families. And so it's just kind of a day-to-day challenge to go forward.
Yeah, it is a challenge, isn't it? So you've been an RT for a long time. Talk to us about your personal perspective in caring for these patients, and talk to us a little bit about some of the ECMO patients you've had to take care of with COVID.
Okay, I just want to talk about, you know, the technology and, you know, the transition we have in this hospital. You know, since I've been here, you know, since, you know, early 90s at the KU hospital under the state. You know, we transitioned to be a public authority hospital. Then we implemented several protocols, and we also acquired a lot of new technology to take care of our patients. So we have seen a lot of improvement in patient care and the outcome. And that probably speaks a volume to the progress that we are making to take care of our patients. In my perspective, you know, I've seen some ECMO patients because I work in the heart center. I think we probably handled 2 ECMO patients in the last couple of months, and you know, we implemented a protocol, you know, that we need to do for the special patients, and so we followed all those guidelines to take care of their patients. So we've been successful, you know, managing and taking care of these patients, but you know, the outcome always is not the way we want it, but we're implementing in the protocols as we told by our intensivist. So I think we're doing our best to take care of all these patients.
I remember reading in preparation for this that you guys have a special issue with COVID-19 patients in that you guys do what we call aerosol generating procedures, where they tend to get finer particles breathing in the air. So you have to take special precautions. Yet, as I understand it, you've not had any respiratory therapists who have contracted COVID-19 from patient care.
Yeah, that is correct. We, once again, at the beginning, we didn't really know a lot, but we did our best to kind of research, find the best practices, and we developed a really thorough procedure outlining what we deemed aerosol hygiene procedures, and then what precautions our staff should take to make sure they're protecting themselves the best way possible.
Rick, how are things going across Kansas? Because your team is also responsible for respiratory therapy in Hayes and in Great Bend and Pawnee and all sorts of places.
Yeah, no, that's a great question. So first, I just want to make a quick comment about respiratory therapists and that, these guys are on the front line taking care of patients every day. A few months ago, we were spending a lot of time talking about lab and testing and detecting the disease, and I'm really happy and honored to be here talking about Respiratory Therapist Week and the great job they do taking care of our patients. They're putting themselves, in harm's way to take care of people first. So I'm just really proud of them and everything they do. And to answer your question about Greater Kansas, Kyle and Belete are talking about some of the great protocols and procedures that they have developed and determined that are best for taking care of our sickest patients that need a respiratory therapist to help them and sometimes help breathe for them. And they have connected the dots, if you will, to Hayes and Great Bend and Pawnee Valley, and shared that information back and forth with our friends and colleagues in respiratory therapy across Kansas, so that the things that we learn and do, we do together, and everybody's patients can get better and have the best care across the states. It's really pretty cool.
It is pretty cool. And I just got to say, again, as a frequent user of respiratory therapy, because I'm working at CF, that's kind of what you do. And a lot of airway clearance, a lot of pounded on chest and things of that nature. And our respiratory therapy department has never been better than it is today. And just hats off. You guys are doing a great job. Thank you all so much. So, Jill, let's see what questions are out there in our community.
First one is from Monica, and she wants to know just what exactly does a respiratory therapist do, and with COVID, how has that changed?
That's a great
Different what
question.
you might do with another patient.
Kyle, it's almost like we wrote the question. We didn't. I'm just kidding.
No.
So, that's a real question. So, Kyle, go ahead. Talk to us about that.
Yeah, we spoke a little bit about respiratory therapy does, they manage the ventilators, they do a lot of breathing treatments for patients who have, breathing conditions such as asthma, COPD, cystic fibrosis, and many other things. Long list. We could talk all day about what respiratory therapy does. How it's changed during the pandemic. I think like everyone else, everyone just has a heightened sense of security and just making sure they're following, the protocols that we have to stay safe themselves, but also, help the patients out the best they can. There are some new techniques that we are using more often now with some of our our critical patients, just to make sure that their lung function improves. But it's definitely brought respiratory therapy to the forefront, I think, a lot more because we play a huge role in this pandemic.
Well, that is so true. And Belit, at the bedside, the ventilators have changed a lot over the years. You and I were around when the MA1,
Right.
the Bears were out there, and
Yes.
you can still see it on some of the shows that some of these, they still got some of those little vents with the pistons moving up and down, and that's not how it works anymore. It's like you're doing kind of a Star Wars or Star Trek thing right there when you're on the ventilator now with all the machine and all the tech. Talk to us a little bit about how it's changed.
I can tell you way back, since we used to work in 44 seat on the fourth floor,
Yeah, I
the
remember
medical
that.
ICU. And I remember, I don't know if it was you or Dr. Simpson, the first patient that I've done lung recruitment was on a 7200 ventilator.
I'm
The
sure I
patient
beat
was on,
Simpson to that, but that's okay. Go ahead.
Yeah. I remember we did lung recruitment on a patient who had ARDS, and then that patient survived and went home. And so when I compare the machine we have from back then now and the current ventilators that we are using today, it's just very, very big difference. And also other equipments we acquired to take care of our patients, on the floor, even in the ICU. We have several devices that we use at our disposal. And also the communication that we have with charting, things like that, that also makes our job so much easier to communicate with the doctors and with everybody. So it's just a big improvement in my
So much
perspective.
Hey,
Yes.
those 7200s, those work pretty well. The Servo 300C, that was a piece of equipment, right? I remember those sorts
Yeah.
of servos, yeah.
Yeah.
I can go back a ways. Let's talk about RT now.
And could you also just quickly define what an Ecmo is?
Yeah, we
And has
will.
that technology changed?
So what happens with Ecmo is that your lungs aren't working very well, and we're having to use so much pressure to put air into your lungs that we can damage the lung, and we have to rest your lung. And the way we do that is we hook you up to a bedside machine by putting a catheter into your veins, or sometimes into an artery or vein or different places, and we take the blood out of your body, we oxygenate it outside, then we put it back in your body. Think of it almost as if it's a dialysis for your lung, and that's probably the best way to describe it. I don't know, you guys, Billy, do you want to say anything? Does that sound right to you?
Yeah, it sounds right to me. Either you can rest the patient on an ECMO, or also the ventilator can work. So it just depends whether it's a VV ECMO or it's a VA ECMO. So both ways, we respiratory have, with the respiratory therapists, we have a role to play in that. And it's been a big game changer for everybody and for our exposure to the field.
Yeah, and it's kind of interesting, we can do different things. If the liver's not working, we can help clear the liver. If the lungs aren't working, that's a big deal, obviously, being a lung doctor. What we can't do is when the brain doesn't work is have a machine that can do that. We haven't gotten there yet. Right. That's probably next in line. We can help with the ECMO can also protect the heart a lot and does that and in some very special ways. And so the technology has just changed dramatically in the last, I've been here 30 years, so we'll start with that.
Julie is asking, please discuss the reduction in ventilator use with COVID patients. And are you thinking that forcing O2 into the COVID lungs may actually be doing more harm in physicians accepting lower O2 standards?
Saturations,
saturation like 85%?
Yeah.
What's normal?
Yeah, well, so normal's over 90, and really it's over 95. And after that, we're trying to do things to help protect the lungs. So let's talk about a lung protection strategy for COVID. Guys, what do you guys want to try? Kyle, Billy, do you want to take that on to start? And I'll try and hit cleanup.
Yeah, sure. We definitely want to protect the lungs like you're talking about, Dr. Stites, and you usually do that with smaller pressures or smaller tidal volumes that we're delivering to the patient, so we're not overexpanding their lungs or causing damage. Like
so we push less air in, so it takes less pressure, and that creates less damage.
Yeah, absolutely. Yeah. And then just making sure we're always monitoring the ventilator, making sure their peak pressures, so that's how much pressure they're getting doesn't get too high, and if we do, then we definitely make some changes to our ventilator strategy.
And Billy, what oxygen levels are you looking to keep somebody above? Because sometimes there's a level of oxygen that you need for all your organs to work, but we know that if we turn up the oxygen too much on a ventilator, high oxygen levels can cause the damage as well. So we try and keep it as low as possible. So what's your target oxygen range for these COVID patients? What O2 saturation?
Well, in general, our protocol is, to keep SATs greater than 92% from the current RT protocol. So I don't know if we follow that guideline. That's what we're using. But for the COVID patient, and I don't know if there is any strict strategy or protocol that we're following, but I'm not very sure about that.
Yeah, I think we're starting to say 88% and above around COVID can sometimes be the right numbers. And again, it's just how much oxygen you have to put in. If you're just laying in the bedside on a nasal cannula, it's not too big a deal. It's when you're in the ICU and you have to go on a lot of ventilators and a lot of pressure. That gets to be more of a concern, I think.
We've had some people asking about training and, oddly enough, boards. Like, do you guys have to take your boards over?
God,
but
yes.
They're asking today, Nancy wants to know, will you talk a little bit about what a respiratory therapist has to do to learn to become a respiratory therapist, your training?
All right. Great question. We got some cool questions coming to y'all today.
Really
let's do it.
These about
Our
respiratory
community
therapy.
is smart.
We
They are.
smart company, smart folks.
Yeah, typical respiratory therapy training is 2-year program, and there are a couple different options where you can get an associate's degree or you can get a bachelor's degree, so the difference between 2 or 4 years there. But you're doing a lot of, obviously, starting out with like classroom work, and then you're spending the majority of your second year in the hospital doing clinical rotations, getting involved with patients, and seeing all that different stuff there. And then obviously once you complete training and you get your degree, then there's thorough training at every hospital, because there's a lot to learn, and as we know in healthcare, everything is always changing, so just keeping up with everything.
So I would just say, my sense about respiratory therapists is for a long time it was very physical. You had to clap and pound on people and things like that. I've been here for a very long time. And now it's both physical and there's a lot of tech involved, right, I believe, because you guys do a lot of tech and sometimes it's pretty fancy tech, like some of those ventilators and some of the stuff you're trying to do with different things to try and keep people's lungs. Talk to us a little bit about that and how it's changed for you in your career.
As for the question is for me, yes. Like when we started out, way back, the equipments were a lot different, and even sometimes I think about it, how the patient survives, because our equipment
we weren't doing it right.
Yeah, well, it's not only that, the machines are not really. It's not really the base machines we have, compared to what we have. Like you have to know your equipment to run it properly. Sometimes if you don't know how to troubleshoot the equipment properly, you can have, adverse effects. So the current ventilators like we have right now is just, they are very different. They're, the alarm system and the strategy that we use, to ventilate patients. Like we use a smaller tidal volume and then, use a lower peak airway pressures to manage these patients. So that's probably makes a big difference. So, in that aspect, that's very, very good. Also, the portability of equipment that we have nowadays, like even using a small, simple equipment like pulse oximetry, we have like handheld and POC that we use to measure patients' oxygen saturation when we're doing our floor care. So that's a big difference, in my opinion.
Yeah, it is a big difference compared to how it used to be when we had to do blood gas on everybody. So, Balit, how long? So, I said you finish college. Are you a respiratory therapist automatically? How does that work?
After you finish your school, you have to pass your board examination. You have to take the NBRC board exam, and once you pass that one, you can get hired. And some places they hire you before you pass your board, and they give you about 6 months to get your board certification. Once you get your board
I'm sorry. Go ahead.
Yeah. So once you get your board certification, you'll become registered. You get the RRT credential. So that's how it works.
So, but it's part of a 4-year college curriculum.
Yes, it's a
4
4-year college. Yeah. Mm-hmm.
Okay. Like nursing is like 2 years of general requirements, then 2 years you're in the school of nursing, and that's kind of like it is for respiratory therapy.
Yeah, there are associate's degree, but the field is definitely moving away from that more towards the 4-year bachelor degrees.
Rick, how many respiratory therapists do we have at KU?
We have about 140 total at KU at the hospital. Kyle can probably dial in the exact number a little bit better than I can, but home team.
You're pretty spot on, Rick.
And they're a pretty autonomous group, right? I mean, it doesn't take a lot of supervision. It's not like pharmacists or something, right? Oh man, wait till it's pharmacy week. I have to be nice to them now. Michelle, Lindsay, I'm just kidding.
Yeah. No, the therapists are out there doing their work. They work in teams, alongside nurses and docs, and they run out and do their treatments and take care of patients as they need. And they make a lot of determinations on their own as far as when therapy needs to change for patients. And sites, they'll come to you and say, "Hey, man, we need to do this differently or change something up here and help get patients off faster."
Yeah, well, they're keeping me out of trouble all the time, which I need a lot of help with that. And then the other thing, just to say, is we focus a lot on inpatient, but there's a lot of outpatient respiratory therapy, and there's pulmonary rehab, there's home respiratory therapy. I mean, there's a whole field out there beyond the hospital.
With COVID patients?
Well, with patients in general, and with COVID as well.
Yeah, absolutely, and it's definitely growing even more. We do things like you mentioned, and we have sleep labs, PFT labs, pulmonary function labs, where we test people's lung capacity, and it's just growing every day, and we're excited about a lot of opportunities that we have moving forward in the next couple of years for respiratory therapy.
All right, Jill, more questions.
Okay, and we have to do at least 2.
We'll do it. We'll get 3. Let's go.
Okay, all right, awesome. Sam wants to know, early on in the pandemic, we were talking about proning patients. She wants to know, are they still doing that with COVID patients now that we're getting away from ventilators a little bit? And you might define what proning means.
Yeah, so proning just means that usually you're laying on your back when you're in the hospital and we treat you like that. When you go on a ventilator, we tend to put people on their back and with the tube coming in. But what we know happens is fluid and inflammation then settles to kind of the back part of the lung. And if we can turn people over, that's called prone, and now you're on your stomach and ventilate you like that, then the fluid can redistribute. You actually do a better job with the ventilator. You can breathe easier. So I'm gonna guess, believe that you guys have been involved with that, or Kyle up in the ICUs doing a lot of prone ventilation. Is that still going on?
Yes, they're still going on. It's mostly on the medical ICU part. They're still going on, right?
And I think we do it a lot in COVID-19, but we actually do it a lot in the ICU now with anybody who's got kind of this lung injury, whether it's COVID-19 or other causes of infection and pneumonia. We'll do it with a lot of different changes. How many patients would you say on ventilators right now up in the medical ICU are doing prone ventilation as part of their protocol?
I don't know really exactly how many patients they're proning. Probably I would say maybe 1-2 patients, but we have a number of patients on a ventilator, but it also changes from week to week. When the COVID cases spike, we may have more patients on the ventilator in the medical ICU, like Unit 61.
Yeah, and just be clear, it's something we do in COVID patients, but it's something we do in lots of other patients as well.
Yeah, I would like to say in proning, I've had patients who are not on the ventilator, who are on the medical floors on low or high flow oxygen, who are proning as well.
Yeah.
Okay, Michael, Donnie, and others need clarification. They are saying if doctors, which I think is the first point of clarification, when you're talking about medical personnel getting sick here and across Kansas and the metro, they're hearing doctors. And they are saying if doctors aren't getting it here, then they must not be wearing their masks out in the public because doctors know to wear their masks.
Yeah, you
They're
bet.
confused.
Yeah, well, sometimes doctors are confused too. So, here's the deal. When we say medical personnel, we don't mean just doctors. We mean respiratory therapists. We mean nurses. We mean all sorts of healthcare workers. So all of us here in the hospital.
And support staff.
You bet. Support staff, the whole team, because it's a team of people that are here. But we do have physicians and other parts of our healthcare team who are getting sick. We don't believe they're getting sick here because we don't really see a lot of infection on the COVID floor per se from staff, but other members of our staff are getting sick, and we're human too, and we don't always wear the mask where we're supposed to. And when community transmission goes higher, that casual thing you don't think is a big deal, like I'm standing across from somebody in the checkout line at the grocery store for 10 minutes for whatever reason, that suddenly becomes an exposure because that person may be asymptomatic and you may be getting it, and if you don't have a mask on, you don't have your face shield on, you can get it. So that's the concern, and so too, and we have, when we've done most of the tracers of the staff here who have gotten sick, you can figure it out because they were out in a group someplace, and it's that group that's going to get you.
Yeah, and of the I said employees, I didn't necessarily mean doctors either. To clarify, 2 of them are not treating patients at all. They're more of administrative type staff. One is a physician, but was adamant about their mask use and reducing risk factors, but also has little children. So, there are issues there.
Yeah.
But for the most part, and neither of our health system colleagues really were seeing patients at all. Even the physician was not seeing patients.
Yeah, and we have a couple of patients. I mean, I know a couple of colleagues who got it just in the last week, and includes people who are really not directly involved in patient care very much, and so you can figure out that, oh wait, my teenager got sick, or my 10-year-old is in school, and there's an outbreak at the school. 10-year-old's asymptomatic, that's frequent, but now the adults are sick.
Yeah.
So that's how COVID works, and that's what makes it so difficult to control.
Okay, so we have one more clarifying question, and now Channel 41 has a question.
Okay, you go.
All right, Michael needs you to also help him understand. You said yesterday you were out walking around over the weekend, and you were very happy to see more mask wearing. If people are wearing more mask wearing, how do we account for the rise that we're seeing right now?
Yeah, I actually think I said that last week. Correct me, but so I wasn't out as much this weekend. But last week I had been down on the plaza, and I think I made the comment on Mondays on the plaza on the weekend, and there are a lot of people wearing masks, so I thought that was great. But if you look in restaurants, people don't have their mask on, and that's a problem. And if you go to the bars, you can look in the bar, you can see the crowded bar, and you're like, uh-oh. And now that it's cold, people are going inside more, and they're still going to restaurants and bars. And when they do that, when you walk into a restaurant, it's like, I don't have to wear my mask. Well, no, actually, you're supposed to keep your mask on until your food's delivered. You take it off to eat, and then you put it right back on again. But I think a lot of restaurants, when you look at the physical distancing, it's really not 6 feet apart between every person, right? I mean, and again, there's a pod of people that are eating together, and so hopefully that's a small group, and you know everybody, and you're consistent. But, that's a risk, because let's say you intersect 3 or 4 different pods, you got 4 people at a table, and you're all from different pods, then all of a sudden you're at the table together. But if that table's not really 10 feet away from somebody, that means the backs of people aren't more than 6 feet away. I think that's a problem.
Yeah, and I think to be fair, you weren't walking by every private home get together where people are there.
Yeah.
Walking by every funeral, every birthday party where people are getting together to celebrate, because those things are going on because they are posted on social media every day. So to
Plus,
be fair
last
with
weekend
that,
was really cold, and I don't think as many people were out. I don't know where they were.
Right.
They may have been inside not wearing masks. I don't know.
So I have Lindsay's question here, but Lindsay, if you're on the line, do you want to just ask? Okay, so she's written on